So welcome to the second run. The idea is to present to you some insights on a new concept or on an option how to work with dental implants in a specific patient surrounding. And the idea, of course, is to have a closer look here at the soft tissue seal or at the soft tissue compartment, the effects we see in computer again blocked. So the idea is to present this concept, of course, also because we looked from the scientific point of view into the data which is related to this system, and we saw beside what has been published with regard to perimucositis and especially to periimplantitis, we see a complete different picture. So two studies, one is from the Graz group from Michi Peyer, led by Sofia Karabataki, and the other study is from Jürgen Becker from Düsseldorf. They finally come up on a long run, 5 to 12 years follow-up with different setups that we have not the issues of periimplantitis. And the question, of course, here is, why is this happening? What happens here around these type of implants? Give you some insights how to build up the story here. A specific gap which we try to restore with an implant. We have the patient's parameter, the biology, the healing, turnover, the maturation. We have the biofilm parameter, niches, how the patient is cleaning, eating habits, and so on. And of course, then the biomechanical device, the biomaterial, what type of device are we placing here on implant, on a restorative level. Actually, when we do a historic flashback, we see that we have implemented into the clinics different type of biomechanical constructions. So we have bone level implants, which are then added by contouring of titanium, of zirconia, of ceramics, early on with gold. And this is what we applied over the decades into patients' mouth. And today the standard would be a zirconia crown with a titanium base. And also with this restorative standard, we have two interfaces. So the one to the implant and the other one between the base, the titanium base, and the zirconia crown, the device. And moreover, when we look at such a construction, we see that we have several different surface configurations. Polished, milled, glazed, veneered, or even here cemented, glued with a resin cement. And just from, let's say, explorative point of view, this can cause in particular cases here in the clinics disharmony, not an equilibrium with the marginal tissues on bone and also on soft tissue level. And this is, from our point of view, or from my point of view, of course, one of the reasons of the causes for this high number, these incidents of periimplantitis. Mid-term clinical outcome, when we remove the superstructure with different type of connections, which is very healthy in the clinics, we see still there are some obvious marginal tissue irritation at the connecting area, which are continuously there 24 hours, 7 days. And by the reconstruction, it means that beside the biofilm, the attack here from the oral environment, the body also has to work to counteract, to handle this irritation from this connection part, whatever type this is. And this brings us to the concept of, again, a tissue level implant with a specific engineered surface here on the mucosal part, where we don't have any gaps or variations in surface quality with this system. So here maybe it's polished, maybe it's by the lab here. It's milled, it's corrected the shape and so on. And here the tissue quality, like with any other tissue level implant, is constant. So the particular case, in a short sequence, we do the proper diagnostics. We open the flap, place the implant according to the protocol, use the drills according to the protocol, and then place the tissue level implant in accordance to the given vertical structure and related to the soft tissue surrounding. The surface color itself, it's not polished, it's not smoothed, it's structured by the company, and it's pretty similar to the structure of enamel. And just a short excursus here, when we have any type of components out of the package from any type of system here, titanium, which is polished, controlled. If I take a drop of blood from myself here, this is an inert surface, and on this mucophilic part here, it's an immediate interaction. And in the clinics, we then adapt the flap according to the needs here, and early healing here is favorable, as with quite often see here with these two-piece tissue level implants. And then over the time, the tissue maturation, the closure here, the prosthetic part, we place the fiber post, we glue, we prep, we do the impression, and then the lab technician can produce the crown, and in the next appointment, the crowns are seated. So we come from a rather demanding condition here to a very, let's say, harmonic outcome when it comes to tissue contours and tissue stability, and also from the prosthetic part to avoid any type of additional niches. So the question here now, which we'd like to interact to discuss here, what is it that makes an outcome like here so harmonic, that the tissue really is nicely adapted to this type of structure? What can we expect here? Is that with any type of tissue implants the case, Tony, or what will you say?
Well, I mean, we have to make the difference between the bone level and the tissue implants. And as a periodontist, we try to use a more favorable system for the tissues, because we know that patients with a history of periodontitis, they have a higher risk to develop peri-implant complications, biologic complications, peri-implant mucositis or peri-implantitis. And for this reason, we prefer to use, wherever possible, tissue level implants, especially in mandibular areas, even in the frontal mandibular area, always tissue level, and we limit ourselves to bone level implants, mainly in the maxillary aesthetic area. But basically, wherever possible, we can only recommend the tissue level implants, because this is also demonstrated in the literature that has the lowest complication rate.
Also,
basically, in this case, I would go for a tissue level.
Yeah. But our perception is also tissue level will limit us in our options when it comes to restoration, especially in the aesthetic area, or when it comes to tissue scalloped contours where we need some more flexibility, as we say. And for that, I've brought here a second clinical case to demonstrate also what the opportunities, the options are with such a system. So when planning that, you would say, okay, if this is selected for an implant, it's a wide gap, what type of implant would you select? A wide body one, a wide neck one, two small ones doing two roots solution. What are the options? And here you have just an insight what is also possible with this type of implant. So we firstly mark here didactically where the round cross section would be, and when we go here for an individualized platform for this patient. We do an individualized asymmetric access here, remove the epithelium, a small mini flap which is rotated to the buccal to the outer part, and then we go through the full drilling sequence as given for that specific implant. And finally, most important, we activate the site. So tissue vitality, bleeding is of utmost importance. So we use here the so-called screw tap, which is related to larger preparation. And most of you would think, oh, I lose initial anchorage or stability. We use that to activate the site. And then once it looks like this, we place the implant. This is the asymmetric platform now designed for this molar. And to give you here now a second insight what may happen when we do this mini flaps or even a flapless approach with punching, what can we expect from the biological reaction here? That's a mini pig model we could conduct. The analytics were done at the University of Bern in Tony's lab, Dieter Bossap's lab, and we see what the idea would be. We have a close condition. The shrinkage here creates a gap. That's the histological embedding here. That's the shrinkage. But in reality, we have the oral epithelium on the upper part and then the direct contact. And you see in the sequence over the days that first it's the blood clot, then we have the granulation tissue. At day 5, we see already the junction epithelium where the yellow arrow is down. And then as an opposite movement, the tissue compartment increases in height and pushes that back. And here also the question, by what time is this seal done and by what time is this seal also stable enough? When would we, for instance, remove sutures? At day 7 maybe, day 8, day 10. And you see in the next image here, that already at day 5, due to the shrinkage to the embedding procedure for the histology, we have forces which in the compartment of the epithelium create a rupture, and a layer of epithelium cells remains on the surface. So the adherence from the epithelial cell to the surface is stronger than the inner compartment strength. That is really impressive. And that gives us also a hint what immediately happens at this surface with regard to cell attachment and cell layer establishment. This is the next one we will do here, ultra structure analytics. This is a junction epithelium cell, and you see on the syconia how happy they are. So they'd like to connect, they'd like to migrate, they'd like to interact with this surface. Back to that. Yeah.
And after a couple of days, the epithelial cells attached very tightly to the surface. When the processing was performed, instead of detaching the entire soft tissue from the implant surface, epithelial layer, epithelial cells was attaching, which indicates that this surface is very attractive to soft tissue cells, because otherwise we wouldn't see this finding in a consistent way.
Question?
Yeah.
If you use the flapless approach and 5 millimeter implant, but you use a 3.5 millimeter punch.
Yeah. What happens then? Yeah.
The tissue. And you say something about that. Will it be a disadvantage?
I would not go for that. I know what you mean now, that you have sort of a small hole and you drill with a reduced protocol and the implant is larger. So the implant is very rough. And of course, it has a sandpaper effect and will, of course, also load some cells, epithelium cells or connective tissue cells. About the connective tissue cells, I have no concern. Epithelial cells, I would not like to have it down. But here it's because you have this collar design. You anyhow have a seal. So your bony access hole should be correct, and the seal comes then with the upper portion of the implant collar. Is it good? Yeah, is it good? Yeah. And you see here now on a short-term sequence, the half-year result, the one-year result with this type of construction. Also in the radiograph, you see now how this molar type of implant supports very well the crown in a correct support, but also refers to the biological architecture, the histoarchitecture of the soft tissue, and tries to avoid any type of additional niches, which we quite often find bone level or tissue level implants where we have this tulip type design. And then 1.5 years later, you see this patient is back into the clinics. You see plaque layers, that's part of the life. He's back with his cleaning habits, and you see how harmonic, how resistant, also how healthy the soft tissue surrounding here around this implant presents. And my question again to Tony would be, do we expect that with any type of tissue level that this embrasure presents like this? Or what is it?
Soft tissues with the same amount of plaque. For me, it was quite striking to see this over and over. Yeah. And even if I look at the clinical images of the animal experiment, that confirms as well this setting.
Do we have this image like before?
Just want to show you the
overview.
Yeah. Would be nice. Possible. So that was the animal experiment, and if you see these images, you see that we had the patent implants, and then we have regular titanium one. So what you can observe is that we have higher recession, and that was consistent in all cases, higher recession of the soft tissues at the titanium one than at the patent one. And that confirms also the histological findings. So it was quite interesting concept, not so easy to explain it, but this is the fact that we over and over observed. So it may indicate that we have something in our hands that should be elaborated further.
No. I mean, one side effect of this fast cell adherence is that we all know that the patients, they don't always follow our recommendations. So I have quite some patients which they come back after the first week for stitches removal, cleaning and so on, and they already started to clean from the very first day because they felt it's something good. And that means also it's not about the suturing, but also about this immediate tissue interaction. The faster this is established, the safer is also then the further healing, the tissue stability is secure, I would say. That would be another effect. Yeah.
That implants zirconia on the market.
Yeah.
The button is retained.
Yeah.
I mean, this would come with the same advantages.
Yeah.
Where do you see specific advantages of not screw retaining a button structure, but gluing a superstructure?
Yeah. I mean, gluing here for me is a regular pros work. That's number one. Gluing, number two, is always on tissue level. So we don't place the implants deep or too deep. That's part of the learning curve. That's the biggest mistake. And gluing means also we have a complete seal. Any screw connection, especially at bone level, I don't like, the body don't like. So there is, yeah. And by the way, it's not about the material that is zirconia. Not all the zirconia behave the same. I mean, we have placed zirconia abutments for 20 years, but they were glazed, they were polished, so completely different. They were screw retained. And here, the point is that we don't change that, we don't alter these intratissular surfaces. So when we go to the lab with a bone level approach, they always, they finish, they polish, they grind, they blast, they glue, whatever they do. They have to. But each and every device we insert is not the same. And that may be also a background, of course, why we have for certain patients where we have more biological side effects than with the same construction type and in others. Yeah. Low torque, yeah, low torque. You see the smart packs there. So we measured here very early on, also within the first hours, what stability behaves. And usually what we do is when we apply high torque, we sort of, we place an additional trauma on the bone. So we delay the bone reaction until destroy the bone. So when we have these aggressive implants, we have quite some scar tissues around the implants. They may work clinically fine, but that's not a biological approach. So maintaining vitality is for us the key. So we apply low torque. Low torque means between 18 to 25 Newton centimeters. That you have to learn. 15 to 20 to 25 Newton centimeters. Yeah, but no, I come also from that group. That's a mechanical thinking, that we think more is better, but here less is better. The point is, if you generate with this implant, which is about 3 to 4 times rougher than any other implants, we have a smear layer, which we also put in this animal study document. And this is a huge osteogenic potential. So here, the interaction is so fast compared to the traditional, let's say, healing patterns, that we have an additional mode and effect which secures a fast osseointegration. So high torque is not beneficial. No. It can work, but we never go for that. Yeah, we never. But it's not because of the implant design, which looks old-fashioned. It's because as long as you place the implant, it's in movement, you generate this smear layer. And as long as you have energy, the implant is kind of in this fluid at the interface. As soon as you stop, the machine stops at 20. When you measure 10 minutes later, an hour later, 2 days later, it goes up. So, yeah, we completely stop this mechanical thinking. And here, you never screw. You don't place any abutment, so you don't need this high torque to withstand any prosthetic device. Thank you for coming, for joining.